Good morning, good afternoon, good evening to all our participants all over the world. My name is Winfried Randrat. I'm the head of the Assembly 4 of the EIS, and together with Sofia Skizza, Secretary of the Assembly, we both welcome you all to this first webinar of our new composed Assembly. When we discussed about topics for webinars regarding our field of sleep disturbed breathing, we did really consider, is the pandemic, is COVID still a problem? Should we still discuss about that? Or has this topic lost its interest? Unfortunately, reality overcame us. And we are still in the middle of the pandemic with already, with again, increasing numbers. So nobody of us realized any comparable situation in our lifetimes. And this actually, as you all know, changed the whole world. It changed also medicine, and it changed sleep medicine. So it's more than important to discuss this topic again. And we can see from participants from all over the world, from Chile to Ukraine, to Myanmar, to Europe, that there is a huge interest in our society, in our field, to discuss these topics. We have two excellent speakers this evening, very experienced in the field of pulmonary medicine and in the field of sleep medicine. And they will discuss with us the two important aspects of the disease, the post-COVID effects from sleep to wakefulness, which is the first talk. And the second will be, what about PAP therapy during the pandemic? Questions that answers, how can we treat our patients still in this situation? And we have two speakers, Professor Steyer and Marisa Monsignore, Professor Marisa Monsignore. And we will start immediately with Professor Steyer's talk. He has been trained in different countries, starting in Germany, then the UK. He has research cooperations with, I think, 5 continents. He is very experienced in the field of respiratory and sleep physiology. And he's the consultant respiratory physician at the Lane Fox unit. And he's also awarded a chair of respiratory and sleep medicine at the King's College in London. Professor Steyer. Jörg, we can't hear you.
Please activate the microphone.
I apologize, but with the remote control, my panel was gone. Can you hear me now?
Yes, wonderful.
Excellent. So now I need to take back control, please. Ali, if I could take back control, please.
Please click again on the screen.
Thank you. So I think it works. I don't have any conflict of interest related to this topic. Thank you very much for the invitation, and sorry about this technical hiccup. Thanks to the chairs for inviting me, the ERS for hosting, and of course to you, the audience, for listening to what I have to say. At the end of my talk, we will hopefully have a little bit more of an overview about the impact of COVID-19 on sleep. We will talk about the effect that it has on quality of life. Winfried mentioned the post-COVID syndrome, long COVID. There are different terms to it. We will talk about this, and we will talk about strategies to hopefully address and tackle these issues, although there are still a lot of question marks around this, of course, as we still start to understand more what is going on and how to best get on top of these issues. So you will see, of course, the problem. This is not news. It affects each and every part of this planet. I think except for the Antarctic continent, there are now registered cases in every country of this world. Hundreds of millions of cases, and many unchecked and untested cases that go unseen. Many deaths, of course, unfortunately. And you see here, this is taken last week from a screenshot from the Johns Hopkins University, the different waves. And we think we more and more understand it, but we have to admit the first wave, we didn't have tests so much, so maybe this underestimates the cases. The second waves, we had already, here in the UK at least, vaccinations phasing in, so suddenly the effect is twisted again. And so what does it mean whether you have COVID or not? And the effect on sleep, do we have actually an effect, A, due to the lockdown, which affects everyone, including those who have COVID, but also those who don't? Or do we have an effect due to the acute scenario of the condition? Or do we have a post-COVID effect? So this is very difficult to put your hand on at the moment, particularly as we still search for definitions, because what is long COVID? So I will give you an overview over the next couple of minutes as to what may be at the moment out there. 2,500 publications on PubMed if you check for sleep and COVID by now, but least of them with hard evidence, no clinical trials prospectively, of course. This is all experience from us, from our colleagues, as to what is going on. However, there's a narrative emerging, and I think you will agree with me once I've shown you the next couple of slides. So let me just get this a little bit larger so that I can see that myself. We have here in the UK looked into the effect on sleep from the first COVID wave. So this was last summer, and we surveyed 843 participants and asked them about sleep, and also asked them about their symptoms and whether they had COVID at the time that they answered all the questions that we had. We wanted to understand to what extent either the pandemic lockdown, an effect that no one really had experienced in their lifetime before, or the infection had on them. And you will not be surprised, of course, this is a selection bias, but 69% of the people that we asked reported that they had noticed a problem with their sleep, that reported unrefreshing sleep. They had reported daytime symptoms, that they were more sleepy than before. A third of the patients had to isolate at that time when we asked them, and 2/3 roughly also reported a quite significant impact on their mental health, with a quarter of everyone that we asked also tending to drink more alcohol during the hard lockdown that we've had at that time here in the UK. So this is a problem on a public health scale. And the developing issues also on mental health and knock-on effects remain largely unaddressed. It's very difficult to provide remotely all the support needed. Now we asked further and asked for symptoms related to one of these 6 categories that we labeled here: insomnia-related daytime symptoms, abnormal behavior-related at nighttime during sleep, sleep disorder, breathing-related symptoms, or related to restless legs, symptomatic, or sleep phase changes that were noticed. And then we looked into the odds ratios, whether patients had actually COVID symptoms at that time, anosmia, fever. In fact, this was largely a time when public large-scale testing wasn't so much available yet. So this was all self-reported. And the most important signal was that on insomnia-related symptoms and disrupted sleep. When we looked into mental health and sleep-related symptoms during the time of a reported infection, then you see here how the odds ratios increased for abnormal behavior, daytime-related symptoms, or insomnia in the subpanels B, C, and D. So the pattern emerged. Disrupted sleep was high up on the agenda. Falling asleep by daytime and feeling very, very sleepy were the daytime symptoms. And nightmares. Nightmares possibly also due to anxiety, even for those maybe who were not infected. And again, if you looked at the subdomains of factors that were associated with these kind of emerging stories that we observed, then mental health really affected everything but the patients who reported here in D more symptoms that were related to sleep disorder, breathing, and also medication use, and that was largely also supported by the problem with alcohol. So this was one of the surveys that we faced, but then in parallel others looked into population-based surveys here from Ipsos Mori and King's College London, a survey that came out again in the first wave here beginning of last year, which described that half of the population said their sleep had been more disturbed. 2 in 5 patients slept fewer hours. 2 in 5 patients had more vivid dreams, and 3 in 10 said they felt less rested. However, some, maybe with very stressful life before in the pandemic lockdown and not going through an infective period with COVID, said actually they slept better as well. But 6 in 10 people in the UK reported that they felt affected by what was going on with worse sleep. Here again, from the International COVID Sleep Study, based on a web-based survey from 14 countries, the incidence and the odds ratios, how likely it is that you were admitted to hospital or to ICU when you had these problems. And besides being male, having diabetes, having depression, maybe also of note here the observation just that obstructive sleep apnea patients were more likely to have this problem. There is discussion around whether this is truly related to obstructive sleep apnea or to the phenotype that we are aware of, which is more likely to be at risk due to COVID, male, obese, elderly emerging. So that takes us basically from the purely observational and survey-based to the more factual-based story, because these patients went to the hospital and they were then also discharged and followed up. But what is long COVID? Where do you cut the line between acute infection and long COVID or post-COVID symptoms? And you can see how complex this is. Even over the last year here, all these kind of publications trying to define what is long COVID, at what stage, at what time, at what cutoff, what organ system needs to be involved. The bottom line is we don't know. At the moment, it's defined as unexplained and against the expectation, long-lasting symptoms. So yes, typically the acute infection is under control, but whether this is a week or whether this is 4 weeks, no one really can put a hard mark on this at the moment. So therefore here, a pragmatic approach. This is from Swapna Mandal in the Royal London Hospital here in London. They looked into all their discharged patients and they asked them with a PHQ-2 and the TSQ regarding symptoms related to depression and related to post-traumatic stress disorder. And they found that, yes, 13% were depressed, 10% had PTSD symptoms. But more interestingly, here you see in the red marked area, the symptoms. Non-improved sleep is quite common. Of between 40 and 50% of all the patients that were discharged from hospital. So likely the acute phase, the infectious disease was over, still suffering with problems. And also if you look at the other symptoms, breathlessness and related maybe fatigue, cough, and other issues, myalgia, something that might disrupt your sleep, highly prevalent to have an impact on these patients. Here from another group around Caroline Jolly from King's College Hospital, they then set up one of the first post-COVID clinics 3 months on. So these patients here were all discharged from hospital, 119 patients who were seen 3 months later and followed up and tested with all kind of physiological tests. But again, look at the symptom scores 3 months on. Persistent fatigue, 68% of them. Sleep disturbance, 57%. Ongoing breathlessness, 32%. And if you look at the left table, you can see 4-meter gait speed, rather low, less than 0.5 meters per second in actually more than a third of the patients. And the sitting to stand repetition test for a minute, completely left scoot. So more than half of the patients, 56 out of 107, really just barely managing a few sit to stand. And then at the bottom, more than a third of the people, 34.5%, with the median struggling and desaturating whilst doing so. So they are weak, they're still affected, and sleep is top of the agenda there. We had a look at the impact on the sleep services, and this was here in the UK. Really, we were cut down by 75% in our activity because many of the sleep techs needed to support ICU. But I assume this will be more covered in the next talk by Professor Bonsignore. We put out statements to try to help the patient, where to find help, and where to find guidance related to sleep apnea, of course, insomnia, the topic of interest, online resources being available, and to public health issues related to stress and anxiety. So in conclusion, COVID-19 infection, we're still seeing more cases at the moment here in the UK. As of yesterday, I think the number was 34,000 newly diagnosed cases, and the numbers are going up, unfortunately, again. Luckily, with the vaccination, we see less problems with acute admission to the hospital. But the infection, as well as the pandemic lockdown itself, has a huge impact on sleep. It disturbs sleeps in the majority of the cases, and these symptoms continue in the acute infection and following the acute infection in more than half of the patients that were admitted to hospital for 3 months and longer. Mental health issues are hugely of concern, and the associated alcohol use during the hard lockdown as well. This is here in the UK seriously affecting long-term follow-up of elective work due to capacity issues. And you can find much more guidance from the national and the international societies, of course, in online resources. This is important as we can't reach out to everyone in person, of course. And now, just to make sure that you all listen to what I had to say, despite all these technical issues, and the ERS will now put these questions with the answers up as a poll. So you can please click on the statement that you find is not true. So A, pandemic lockdown has affected the public health and patients in lockdown. Long COVID may lead to disrupted sleep and daytime symptoms. C is there are no mental health issues in patients with COVID pneumonitis admitted to hospital. And D, a large proportion of hospitalized patients with acute COVID may suffer from fatigue, breathlessness, and sleep problems. So please, if you click on the poll now, then you can hopefully submit your answer, and we will see the results in a moment. So Ali, if you could bring up the poll result, please. And yes, I'm very pleased to see that you all got the message. So C was not true. There are no mental health issues. Of course there were. And we do see that this seriously impacts on outcomes. If you think back to the table that I've shown you from Dr. Mandal's work, the ones with high depression scores, high PTSD scores were actually much worse on average on most of these kind of outcomes that they measured. Another question, 1 minute to go, we have, hopefully the poll works. So what is the most likely impact of COVID-19 infection on sleep? There are 4 options. So A, there is no impact of COVID-19 on sleep. B, COVID-19 may cause central hypoventilation syndrome. C, an infection with COVID-19 may disturb sleep, potentially lasting beyond the acute infection period. And D, direct and indirect effects of COVID-19 on sleep are exclusively caused by anxiety. So please cast your vote now, A, B, C, or D, and then submit your answer. And Ali, whenever the results are in, I don't want to overstay my welcome. So C is, of course, correct. We are not aware that COVID causes central hypoventilation syndrome, and it's not exclusively caused by anxiety and the effect. So C is correct. An infection with COVID-19 may disturb sleep, potentially lasting beyond the acute infection period. From all that we know, frequently at least 3 months or longer. Thank you very much. That is what I wanted to talk to you about in the shortness of time. I'm sure you have many more questions later on, but now I hand back over to the chairs and to welcome the next speaker. Thank you.
Thank you very much, Jörg, for this very stimulating talk. And as you said, we will have a lot to discuss. And for those who have questions, please use the chat function and choose a panelist and participants to send the questions so that everybody can read the questions. Thank you so much. And I hand over to Sophia.
Thank you, Winfried. It's my great pleasure to introduce Marisa Bonsignore, professor of respiratory and sleep medicine at the University of Palermo, one of the pioneers in our field. She had long research periods abroad, mainly in States, maintaining important research collaboration. She's one of the ESADA founders. She received many prizes and honors, and recently she was fortunate to receive the ERS Dual Lecture Award. She has an impressive and continuous activity in ERS. She was the former head of the Assembly 4, and recently she was elected also in the Scientific Committee of ESRS. And of course, she has a numerous publication in peer-reviewed journals. And I'd like to add that she's very, very supportive to new people that they want to have their training in sleep and learn from her. So Marisa, the floor is yours, and we are looking forward to hearing your presentation.
Well, thank you for the introduction. I hope to be up to the expectations you raised. So my task today is to talk about PAP therapy during the pandemic, and I will try to address some questions and provide, if possible, some answers. I have no real or perceived conflicts of interest that relate to this presentation. There are just consultation fees. What are we talking about? Well, first, we should talk about sleep laboratories during the lockdown phase, because even though now the pandemic is not going to be as serious as it was when there were no vaccines available, still we do have to adopt some precautions given the widespread presence of the infection still now. Then we will talk about PAP therapy during the pandemic and what is next. So we'll concentrate mainly on telemedicine, which is a very hot topic these days. So as you know, the activity of sleep labs during the lockdown, the first lockdown, dramatically decreased, and there was some increase in distance follow-up by phone calls or telemonitoring, but was not as big as we would have liked. In fact, there were many centers starting telemonitoring, but there were also some centers stopping telemonitoring. And this was probably due to the shortage of personnel, because personnel was moved to the COVID-19 units. This affected northern countries in Europe by 40% and much more southern and central Europe. So what were the reasons for shutdown of sleep labs? Besides the shift of hospital personnel, patients were at home during the lockdown, and also there was a high risk presumably associated with procedures. For example, both sleep studies and especially PAP titration studies could cause dangerous aerosolization, so spreading of the virus in the environment. So the alternatives available were follow-up on the phone or by telemedicine, but some degree of activity remained for urgent consultations. These are very recent data still in press from the Swedish Sleep Apnea Registry, where they compared the number of tests they did in the years in 2020 compared to 2018 and 2019. And you can see that there was a quite stable decrease in diagnostic sleep tests, and that was minus 43%. And remember, Sweden did not ever go into a real strict lockdown. But still, diagnostic sleep tests were lower by over 40%. PAP treatment start went down in the beginning of 2020, but then gradually came up. So the average reduction was only 17%. What is really interesting is the fact that the device treatment start sharply fell and remained low, and actually got lower in late 2020 compared to initial 2020. And this may be due to the fact that dentists were a high risk, so I tried to avoid possibly high risk procedures, or this could also reflect lack of communication, active communication between teams of sleep doctors and dentists labs. So, but this confirms that even in a country with a relatively low decrease in movement or contacts, there was a decreased amount of sleep lab tests. With Sofia, we did, and a lot of other European experts, including Rafika, who is a pediatric sleep doctor. We tried to put some order among the different attitudes in different European countries. So there is a huge heterogeneity in what different countries did during the pandemic. And this is due to different regulation, different health systems, which make things a little more complicated. However, we were able to put together some schematic representation of what should be done. So we tried to summarize things. And so there was a pre-screening before access to the sleep lab, check of temperature, so if there were signs of fever or contacts or suggestive symptoms, then patients were not considered suitable for sleep tests. Whereas on the day of the access, there was questionnaire, body temperature measurement, and some general precautions to avoid crowding, and some general protective measures for patients that we all know very well. Diagnosis was a little more complicated, but while in laboratory PSG or polygraphy was decreased sharply in numbers, home polygraphy, home sleep tests were preferred. So they were kept in most laboratories all over Europe. However, there were some protective measures for patients, like wearing the surgical mask, keeping distance and hand hygiene. Other general protective measures for health professionals, and use of disposable equipment whenever possible to use it, together with clinic precautions for the physical space and equipment according to local recommendation. What was really a problem, however, was PAP titration, because here a higher level of protection was required due to the risk for aerosol generating procedures. Remember that at that time we were not vaccinated. So vaccination started beginning, at least in Italy, beginning of 2021 or late 2020. So it was recommended not to use humidifiers. Also to use non-leaky full face masks with 2 filters in order to avoid dissemination of droplets. And PAP treatment initiation was also at home using telemonitoring in uncomplicated cases. However, you can see that reimbursement policy is another important factor, because there are still several countries in Europe where the reimbursement for home sleep studies is not in place. But again, in laboratory PAP treatment was only possible whenever the epidemiological situation was relatively good. The position document of the ATS did a very nice synthesis of how to behave according based not only on prevalence of COVID-19, so increasing level of mitigation strategies as COVID-19 prevalence in the population was higher, but also according to the need of the patient. So there were patients who did not need visit in person, who could do well on telehealth visit. But there were also other patients who badly required to be seen by a doctor, where low-level mitigation strategies could be used in case of low prevalence in the population, but COVID-19 testing was required before visit with maximal mitigation strategies whenever the epidemiological situation was more severe. And in between, there are patients where the visit was at discretion of provider and patient. So, and this is the scenario where we are still moving, more or less. But there are interesting questions. For example, did patients on PAP continue treatment during COVID-19 lockdown? Now, all recommendations said that sleep apnea treatment or home NIV, non-invasive ventilation, should not be stopped during COVID-19 pandemic. However, if a patient on PAP develops fever, she should sleep in a single room in order to avoid potential virus dissemination to other family members. And this was especially important during the lockdown. Then maybe because of fear of the respiratory infections, a study from France found that actually adherence to CPAP increased during the lockdown, possibly also because people were at home, so maybe also the lifestyle changed and there was more possibility to concentrate on things like health, being at home all day long. But on the other hand, Jean-Louis Pepin, in a paper on attitudes by patients, commented that patients received little information on precautions for COVID-19, mainly by providers. However, if you ask patients on PAP treatment at home whether they had infections, so COVID infection, they did not report increased infection rates compared to the French general population. So it does appear that patients who are on treatment are not at a much higher risk than the general population. Conversely, we also know that there are reports where it's claimed that sleep apnea increased the COVID-19 mortality and hospitalization. And this is a paper published in the American Journal of Respiratory and Critical Care Medicine. And you see that there was actually an increased risk of death and mechanical ventilation or ICU admission. But when the analysis was adjusted for BMI classes and comorbidities, the number became non-significant. So my personal belief is that probably comorbidities and especially obesity, as it has been reported repeatedly, did impact on COVID mortality and pneumonia severity, but not sleep apnea per se. The results of different studies are summarized in this meta-analysis that, again, with the previous caveats I've said, show an increased chance of having severe COVID-19 or ICU admission or need mechanical ventilation or mortality for sleep apnea patients compared to non-sleep apnea patients. We'll see more on this, but there are very, very few data on epidemiology of COVID-19 in sleep apnea patients. So how is it now? Well, sleep services continue to suffer shortage of personnel and also space. So the situation is not exactly back to normal yet. And this means a high risk of patients for long waiting lists, underdiagnosis, or delay of treatment initiation. In our center, instead of doing sleep studies and starting titration in the clinic, we collaborate with home care providers, and they perform sleep studies and titrations at home, but we are quite careful to supervise closely this process and also have a pretty early follow-up visit, because we haven't seen the patient for a month or so, at least during this process. So, however, providers do have expenses for personnel going to patients' home, for disposable parts of equipment for diagnostic tests and titration. So there is a need to recognize this service and set a reimbursement policy. And this is not only in Europe, which is largely based on public health systems, but has been also underlined by in the US. So it is a general problem. So the future is probably telemedicine. Not to say that telemedicine will completely substitute the sleep lab, because there will always be patients who are better treated in the sleep lab or studied in the sleep lab than at home. But certainly this is going to increase not only in sleep, but also in other fields of medicine. Recently, the position paper on telemedicine by the American Academy of Sleep Medicine was updated, and you see that they underline there are problems with not only personal data protection and continuously evolving legislation, but also problems with the use of telemedicine, because on one hand, this can reduce health inequalities, making, for example, possible for patients who live far away from big sleep centers to be followed by highly specialized personnel. But of course, this requires technological improvement and also some competence, e-competence by the patient. And our frail patients are usually old, maybe cannot use or don't own a smartphone. So there is also the possibility that health inequalities may increase due to telemedicine. Now, Johan Verbraken just sent me this paper, very nice paper on sleep medicine clinics in press. On telemedicine in sleep. This is an extensive paper, as is 30 pages long, really an impressive piece of work. And I took some of his major points and tables for to show you, because they summarize nicely the problem. First of all, we have problems. We're going to have problems with the platforms for CPAP telemonitoring, because unfortunately there are several platforms, but they do not talk to each other. So for a doctor, it would be good to have a universal system in order to access different CPAP telemonitoring platforms for different patients. But this is hardly feasible, because it needs, there are problems of data encryption by the communication device. So it's technically complicated. But also there is a problem with the type and quality of measured data, because this depends on the manufacturer's technology. And even detection of respiratory event, for example, is based on the magnitude reduction of the flow signal, but the baseline value is not defined and does not even remain constant during sleep. So how reliable are these systems needs further studies. And also, we need to establish filters for intervention during telemonitoring. He talks about a tsunami of data that can fall over us. So the alarm threshold for a physician should be set, for example, regarding compliance treatment, the leaks, but the leaks vary according to the ventilator and also or the mask manufacturers. So this is going to have a variability even for the same ventilator if one uses different masks, as we all do. And also the residual AHI, this shows less variability because it's generally between 10 and 15 per hour. So the decision tree he proposes in this paper is that we should check everything, because if there are problems, they need medical support if they persist. For example, central events need medical support, whereas obstructive events may be due to insufficient pressure, nasal obstruction, or full face mask. But until we have solved all these problems, we cannot do continuous telemonitoring. So it's mandatory to have a strict control of these factors in order to ensure the best quality of care. There is another good thing of remote consultations. This is a study by the group in Grenoble, not in sleep apnea patients, in a group of patients undergoing a weight change program, weight loss program. And you can see that the change in weight was actually pretty low during the lockdown phase, but post-lockdown, the decrease in weight was larger in those who had a closer, so a higher number of remote consultations. So this means that telemedicine can increase compliance not only to CPAP, which we more or less know, at least in the first period, but also to other type of treatment. And this is why we're going to see more and more throughout medicine as the use of telemedicine is concerned. So in conclusion, I personally believe, and we all, I think, do, that the COVID-19 pandemic is going to be a turning point for management of both adult and pediatric patients with SDB, sleep disorder breathing. For pediatric patients, for complex syndromes, there will always be the need to do sleep studies in the lab. But for example, there is an increasing pediatric population using CPAP for sleep apnea. So this can well be followed by using telemedicine. Telemedicine seems as effective as usual care, and the patients like it very much because it saves time, saves the need to be accompanied to the doctor for elderly people. So it has a lot of good things. And also, most importantly, in this situation, it's also safer. However, we do need to define standards and solve problematic areas, including use of telemedicine in disadvantaged groups. But I think the best will be to start using it in order to identify these problems. And there is a need to develop and test e-health management modes in order to adapt them for sleep medicine and verify their cost effectiveness. And finally, development of telemedicine will probably require investments and also reimbursement policies to be adopted by the different public health systems in Europe. I thank you very much for your attention.
Thank you, Marisa, for this comprehensive overview and for providing us with the latest updates and the latest informations, highlighting the importance of telemedicine and at the same time its limitation and its problems as well. Nothing is ideal, but it's a useful tool in the hands of the specialist. I want to ask you if there evidence regarding potential benefit of effective CPAP treatment in the adverse risks from COVID-19 infection in ONSA patients.
Well, there's not much on the use of CPAP, but apparently, as the PEPEN papers shows, if patients are using CPAP, usually they tend to stop CPAP if they get COVID or get hospitalized. But on the other hand, if you think of the disease is currently treated with positive pressure. So CPAP may actually mitigate the bad effects of COVID infection in the lungs. But there is no proof. I don't know if anybody knows about this, any on the panel, but I personally haven't found much on this.
We may need prospective studies towards this to resolve this question. They share common consequences and for inflammation as well as coagulation status, but I think that we need prospective studies for that. I don't know if Winfried or Jörg wants to comment further on this.
Yes, thank you. Certainly, the theoretical mechanism of CPAP works very well to treat the respiratory issues in these patients. But then in practice, we do see, because they are hypoxic, they are hypocapnic, typically at that stage because they're so tachypneic, and they don't necessarily in an acute admission to a hospital, to a respiratory ward, to an HDU, or to later on maybe ICU, tolerate so much mask treatment. That's what we've seen. So high flow nasal oxygen often to treat the acute hypoxic respiratory failure seems to be more favorable, really. And then when it comes down to fatigue of the muscles and the question whether they do need ventilation, then often the non-invasive interface, the CPAP mask or the NIV, is not really tolerated because they're so agitated. And that is then where the intensive care specialist needs to make the call whether to intubate or not. I guess this is something where we've learned over time. I have seen quite a bit of manipulation in physiology labs with CO2 levels up and down, but in the first wave here, we were all aware that the call to invasively ventilate is a very significant decision, because then the mortality, we all heard about the outcomes here, it was 50-60% survival maybe. In turn, up to half of the patients maybe died. So in the second wave, we've seen here that much more often we tried with non-invasive tools, high flow nasal oxygen, and then in the improvement phase as well, non-invasive ventilation, maybe via facial mask, kept the patient off the invasive ventilation. But you needed to keep your coolness, not to intubate on occasions, because we regularly had patients with a CO2 of 2 or 1 sitting there on an ward and struggling with tachypnea.
Yeah, before adding something to Jörg's comment, I would like to invite all participants to send us your questions, but also your opinion and your experience with both acute treatment of COVID, telemedicine, sleep problems. So please do not hesitate to send us your impression, your experiences, and also, of course, your questions. I think I would like to add one point. I think we have to be very clear, as Jörg pointed out a bit, that we have to differentiate between hypoxic and hypercapnic failure. And if you have hypoxic failure, then we do not really, if you have hypoxic failure, then we need oxygen and high flow oxygen, but we do not really need hyperventilation, as patients already hyperventilate. So we can use CPAP to open the upper airways, as we all know, but also counterbalance atelectasis, ventilation perfusion mismatch, if so. But in case of hyperventilation, low CO2, we do not really expect these problems. So in that case, I would not argue too much for CPAP. But if we come to more muscle failure and beginnings of hypercapnia, then we would try to start with non-invasive ventilation. And as you said, be very critical with invasive ventilation, but in some cases we cannot avoid, of course.
If I may, the question was more for the long-term PAP compliant OSA patients that may have a protective effect from developing serious forms of COVID infection, or even leading to respiratory failure. And if the compliant patients may be of lower risk than other patient population. And I think that there is a lack of evidence towards this. There is a potential link between good compliance rates, given that they share some common pathophysiological links between the two diseases, but we need prospective data, and it's interesting to see that in the future.
Yeah, no, that's a good add-on remark, Sophia. And actually, in the long-term treatment of patients who happen to have obstructive sleep apnea with CPAP and who use CPAP therapy throughout a COVID pandemic and might get the infection, the COVID infection causes a pneumonitis and airway inflammation. And what we often see in the OSA cohort is that there's associated phenotypic obesity, and that these patients actually breathe at very low lung volumes, very close to the residual volume, sometimes in the dependent parts of the lung in supine posture at the closing volume of the airway. CPAP actually inflates not only the upper airway, but also lifts the functional residual capacity, and therefore avoids shear forces of the lower airway, actually causing brain expiration, a collapse, and therefore it is possibly that these kind of shear forces that are offset by CPAP therapy, by breathing at a higher volume and by opening the lower airways as much as the upper airway, could actually be beneficial. But I agree, there's no prospective randomized data on this.
Well, if I can add the last comment is that my sleep clinic never stopped working because I was the only one in the city, in the entire city, still working with sleep disordered breathing clinic. I haven't seen, so the patients on CPAP who came to my observation during the last year were honestly quite few. And they were either asthmatic, obese women, or very fat guys. The average sleep apnea patient didn't come up by saying I had COVID. But meanwhile, you have to consider that there are so many factors in getting the COVID. So if you stay home and you are locked in the house and do never go out, it's very hard for anybody to get infectious diseases. So the problem is that we should know more about exposure and about disease development, which we have no idea, even probably in non-sleep apnea patients. So more or less, this is where we are now.
Thank you, Marisa, very much for this comment. Jörg, I would like to go a little bit to the questions we have,
Sure.
and we could possibly combine two questions. You mentioned that it's so difficult to find the border between acute and post or long COVID. So one question is, do you use post-COVID or long COVID? Do you make any difference on this question, or is it just synonym? And the second question, which is, I think, much more tricky, what are the mechanisms underlying sleep disturbances after a cough infection?
Yeah, thank you. So a lot of what we're talking about is purely descriptive. So post-COVID, in theory, everyone qualifies if you had the infection as post-COVID. But long COVID, in contrast, is more defined. It's actually something that patient groups came up with as a more post-viral infection state involving a lot of lasting symptoms, and which was favored by public involvement and charity groups. So with that in mind, it's really difficult to completely set the border there. But maybe a little bit in line with that, because I mentioned, yes, we all might have had an effect due to the lockdown, and or the acute infection, and or post-infection symptoms. So there's never an exclusive phenomenon. Someone who has gone through the stage of infection might have an effect due to all these three factors. They might have been worried and anxious and developed insomnia whilst they were in lockdown. They might have had problems with hypoxia, developing sleep disorder, breathing to the degree that when you're hypocapnic because you're tachypneic, you develop central sleep apnea, and they had maybe sleep fragmentation because of that. Then they might go into the state where they are over the infection, but still they're tachypneic, still they have maybe myalgia, they might have thrombotic events somewhere in their body, and therefore what we do see, of course, is you get this kind of PTSD symptomatic from hospitalization, maybe from invasive ventilation, but you might also have inflammatory responses. We're still learning about this because the virus is neurotropic as well. So anosmia, that's the effect on the virus on a nerve, on the central nervous system. So we are learning about this, to what extent actually central activity of the virus might cause direct problems like sleep disturbance or mental health issues, possibly. But most likely, if you've gone through all this, it's a sum of all of this. Your body suffers, your mental health suffers. And although we like to divide all this, mental, physical health, it's not, you can't make that distinction. You are one entity and your health is defined by both mental and physical health. And so that's at the moment the problem we are facing. So post-COVID, it's currently defined as if you continue to experience symptoms beyond the expected phase of infection. So I would think if you're hospitalized and you're going home still with symptoms and in the recovery period, and a couple of weeks on you still experience symptoms, well, certainly 3 months on, that is a hard cutoff, I guess. I mentioned the 1 week earlier on because that would be somewhere, the truth sits probably somewhere between 1 week and 3 months, where you would say this is beyond the expected range of where you would expect the symptoms to have resolved, unless there is ongoing, maybe long COVID, or however we're going to call this in future.
It's always a pity to ask for short answers in this complex questions. No, but I would like to address at least the remaining questions. So one comment is here. I would add to the mechanisms the adverse environment related to the hospital in terms of light exposure, noise, lack of routine, and among others. So very important addition, I think.
Absolutely.
But one other aspect, maybe you or Marisa can address it. It goes to steroids. The question is of patients treated with for organizing pneumonia. Do the steroids have impact on sleep? As we know, steroids can impact sleep. So, do you think that could be one other aspect to, in addition to the things you mentioned?
Yes. Marisa, would you like to, or
just go ahead.
Good. Thank you very much. Sorry. So steroids have, of course, neurological effects. We know about this in other contexts. The problem is you're talking about hospitalization and the effect on circadian rhythmicity, sleep disruption, noise exposure, worries, etc. So in combination with the steroid effect, steroids have also an effect on the muscle function, on myopathy, on the metabolic function, and all this can be really difficult to figure out. At the moment, I would say yes, possibly. There is an effect, particularly in the acute scenario. Yes, possibly because dexamethasone is given around the acute infection before patients deteriorate, ideally. So, and most of the patients should be weaned off by the time they go and leave the hospital. And I'm not so much aware necessarily the typical patient who is walking out of the hospital that they remain on steroids, but of course those who have more severe end organ damage, meaning on the lung and fibrotic changes, they stay for much longer on these kind of immunosuppressant doses of high dose steroids, and there it could impact on sleep. But then again, the organic damage is then so severe on the lung, and you see these kind of fibrotic destroyed lungs. These patients have many other severe organ failures, and they will have in itself an impact on their sleep, particularly if you've been long-term on the ICU and your lungs are broken like this. Often the patients might have had a stroke, other issues as well, and it's very difficult at the moment to clearly dissect which is which.
I see two additional questions. One to Marisa. If a patient has been vaccinated, should any less precaution be used if commencing CPAP overnight in the lab?
Well, this is a difficult question because we do not have data again. I think that at large, it is recommended to use precautions still in vaccinated people, even though in theory this should not be so. But the new variants, I think, impose some caution again for a little more time. So I would not change the precautions for the sleep lab. We keep using masks indoor. So why shouldn't we decrease the level of the protection for patient and personnel if we're using if we're doing a CPAP titration in the lab. There is no reason. So I would be cautious.
I just get the message at the end of the webinar. Sorry for that. There was one further question on diffuse lung disease.
Yes.
So is interstitial thickening, last comment, very short comment, do you already have experiences with lung fibrosis over the long term or longer term? So only personal experience, Marisa? Lung fibrosis as a post-COVID complication? Not yet?
Not yet. We didn't see many patients overall. So maybe in big cities you have more experience with that.
Jörg, any comment?
London was hard hit in the first wave, and yes, our ILD team has extra clinics for these patients. We do see this, unfortunately, quite a bit, particularly those who required long-term ventilation.
Okay.
Thank you so much. Thank you to both of you. It was an excellent webinar, both very stimulating presentations, very stimulating question and answer session. It's always the same. We do not have enough time, but that calls for another webinar in the near future. Thank you so much, Sophia. Sorry that we did not have enough time, but that's a good sign, I think.
Yeah.
So thank you.
This is good.
Have a good time, everybody. Stay healthy, and I hope to see you soon in one of our activities. Thank you so much. Goodbye.
Much.
Thank you.
Bye.
Thank you.
Goodbye.
Take
Thank
care.
you.
Bye.